Hello, I'm Dr. Ken Landa. Thanks for watching. Let's talk about vulvovaginal candidiasis. It's one of the most common reasons why women seek medical care. It's due to a yeast known as Candida albicans. When it excessively grows on the vulva and in the vagina, it causes symptoms of irritation and itching, quite severe sometimes, pain during sexual intercourse, redness around the vagina, and a discharge that typically is thick, but it can be white and watery. It's the second most common vaginal infection right after bacterial vaginosis. It's more common than trichomonas. Sometimes it has to be differentiated from a normal discharge. We call it leukorrhea, physiologic discharge, or in postmenopausal women from atrophic vaginitis, or from women who apply cosmetics to the area, or sexual lubricants, a contact dermatitis, or a vulvar dermatitis, or vulvodynia. It's rare in prepubertal girls. It's relatively infrequent in postmenopausal women unless they're using hormone replacement therapy. 70% of women are going to have at least one vaginal yeast infection during the course of a lifetime, and we refer to vaginal yeast or vulvovaginal yeast as synonyms. They're the same thing. 50% of the time, women are going to have at least 2 infections. And in the course of any given year, about 20%, 1 in 5 women, are going to have at least 1 infection. And somewhere between 5 and 10% of women are going to have at least 4 infections per year. An infection with culture positive, because a lot of women treat themselves and just assume that what they have is a yeast infection when indeed they don't. So in order to make the diagnosis, a culture really is necessary to say that it's recurrence of exactly the same thing. Now, Candida albicans is present even in the absence of sex. It's present in the mouth and the digestive tract. It's present in the colon, present in the vagina. It's considered part of the normal flora. And at any given time, 10 to 30% of sexually active women are going to have the yeast present in the vagina. And over the course of a year, 70%, at least at some point in time, are going to have it. So it's transient, it's asymptomatic, and oftentimes it's a commensal. It doesn't cause any kind of problem. It's not really considered a sexually transmitted infection, but it's more common in people who are sexually active and can be passed from partner to partner during sex, oral sex, vaginal sex, anal sex. The risk of infection in a male consort of a lady who has a vaginal yeast infection is less than 15%, typically an itchy rash, red rash, present on the glands of the penis. Some lifestyle factors may influence the likelihood of developing this kind of infection, certainly more with sexual frequency, more with women who douche, because it changes the pH, it adds things to the vagina and takes some of the good bacteria out. Certainly women who use vaginal sprays and spermicides and IUDs are at higher risk, and probably the birth control pill and a history of allergies might increase your risk. Women who have uncontrolled diabetes, or women taking some of the anti-diabetic medicines now that push more urine containing sugar through the system. Well, that excess sugar in the urine can increase the risk of vulvovaginal yeast infections. Antibiotics certainly are a classic cause, especially the broad-spectrum antibiotics like Keflex or doxycycline, some of the other medicines, and even steroids, prednisone. Well, women who are obese are at higher risk. Women who have poor immune function. Poor immune function may be because they have some connective tissue disease like lupus or rheumatoid arthritis, or taking the medicines for those conditions. That decreases the body's ability to keep the candida out. The vulvovaginal yeast infections tend to be in higher concentration or higher likelihood, greater likelihood from mid-cycle to the time of the menses because of increased hormone secretion. And talk about hormone secretion during pregnancy, it's extremely common to get vulvovaginal yeast infection. The estrogen concentration is increased 30-fold. The progesterone concentration increased about 10-fold. And those hormones act to decrease the body's ability to fight the yeast, and they decrease the body's own production of its antimicrobial substances, the body's own antimicrobial substances, and that allows a proliferation of yeast, especially during the last trimester. But a person can get vulvovaginal yeast infection anytime during pregnancy, very common, and it seems that the hormones and the hormone change tends to cause the yeast that's growing harmlessly to change from the spore form, or the Y form, into the H form, the hypho form, the form that looks sort of like a mini pencil. And it's that mini pencil that seems to invade the epithelial cells. Well, the antibiotics and the estrogen don't really cause the yeast infection by itself. What they do is they change the concentration of lactobacilli and other kind of organisms that are present in the vagina. And it opens up some space for the yeast to get to the epithelial cells and to attach. And also, the so-called good bacteria are manufacturing a variety of substances that help keep the yeast at bay. And by the way, vulvovaginal yeast infections are not related to wearing tight clothing or the type of underwear you wear or your personal hygiene. But if you do have a vulvovaginal yeast infection, you have a greater risk, if you come in contact with the HIV, of catching that. Now, the vulva has its own unique microbiological niche, vagina too. We have, in the vagina, we have the lactobacilli. They compete for the nutrients. They compete, as I mentioned, for the adhesive sites on the epithelium. They produce some antibacterial substances that keep the yeast from growing. They produce hydrogen peroxide. They produce some fatty acids that inhibit the yeast growing, and they keep the vagina at a pH where the yeast really doesn't like to grow, a pH of about 4. Now, when we talk about yeast infections, we talk mostly about Candida albicans. That's 85–90% of the cases. But that means that non-albicans type of Candida accounts for about 15% of yeast infections. And the incidence is increasing, especially as more women have immunosuppression. And when women treat themselves or are treated by the doctor for vaginal yeast infection, and the yeast infection doesn't seem to go away, and the diagnosis is correct, it might be because it's one of these non-albicans type of Candida that tend to be resistant to the standard medicines we use. There's also another kind of a yeast called Saccharomyces cerevisiae, and sometimes a woman can actually get infection with 2 different types of Candida, Candida albicans, say, and Candida glabrata. Uncomplicated infections, typically just Candida albicans, almost all of the cases, but with complicated cases or recurrent cases, maybe only 70% due to Candida albicans, and that's the one that's sensitive to our therapies. And there's an increased incidence with recurrences of having 2 different types of Candida, again, the Candida albicans, Candida glabrata. The symptoms aren't really all that specific, so just by looking we can't differentiate from bacterial vaginosis and gonorrhea and trichomonas in many cases. The symptoms as far as the vulva is concerned, well, itchiness, soreness, irritation, often quite severe, sometimes less so with Candida glabrata. There's redness and swelling and fissures. And then if we talk about the vagina, there's pain and discomfort during sex. We call it a superficial dyspareunia right at the entrance to the vagina, as opposed to the deep dyspareunia, deep discomfort that's present with endometriosis. The vagina is red and inflamed. There's pain or discomfort oftentimes while urinating. And the vaginal discharge tends not to have an odor, as opposed to, say, bacterial vaginosis. Well, even if the symptoms are limited to the vulva, you have to realize that the vagina is infected. And the question is, how did the yeast come in the first place? Where did it come from? How did it get into the vagina? Well, it could be from local transport from the area around the genitals, area around the anus, perianal spread, digital spread through fingers, or sexual transmission. Could be from spread right through the skin cells without going to the outside, but right through the skin cells into the vagina. That's certainly possible. And direct contact with yeast discharge. Well, the discharge is variably present. It tends to be acute and florid and thick and cottage cheese-like with copious amounts of discharge and a lot of the yeast cells, but it could be at times absent or a mild discharge. It could be thin and watery with few organisms, even though it has a severe itch. The cervix itself is not involved in this kind of a situation. So the cervix is not inflamed, there's no cervical discharge, there's no motion tenderness. We have to differentiate other kinds of discharge from other reasons. So is this a sexually transmitted infection? Is it from trauma or abuse or a foreign body that's present? Is it from a malignancy or an immune disease? Or is it maybe part of a bowel disease like inflammatory bowel disease, regional enteritis, Crohn's disease? Or is it a skin condition like psoriasis or eczema? Well, also have to make certain that we're aware of the normal physiologic discharge and not confuse vulvovaginal yeast infections with leukorrhea. That's the typical transudate that's secreted through the vaginal epithelium and from the cervix that's present normally. And a normal woman who's in her reproductive years, not on hormone therapy, is going to produce somewhere between 1 and 3 grams a day of this leukorrhea, this type of a discharge that's clear at the time of ovulation and tends to be thicker and whiter during other phases. And you say, well, it ought to be relatively simple, but about 10% of women referred to major medical centers for evaluation of recurrent yeast infections actually have nothing more than prominent physiologic discharge, so no disease. So making the diagnosis, the woman goes to the doctor, complains of the typical symptoms. The doctor might look under the microscope to see if there's yeast present, but might also take a culture. Even if the doctor can't see any yeast at the time of examination, many of the women will grow the yeast in the laboratory when it's cultured. Can do some other tests to rule out other kind of diseases. The interesting thing is, if we do a culture, is that really going to give us important information? Well, we said 10 to 30% of the time, at any given moment, women are going to be positive, and 70% of women are going to be positive at some time during the course of a year. So just because we have a culture that shows the yeast is growing, that doesn't mean that the yeast is responsible for your particular situation. Well, if we look at uncomplicated yeast infections, vulvovaginal yeast infections, less than 4 a year. If we look at the complicated or recurrent vulvovaginal yeast infections, more than 4 a year. And if you happen to have the recurrent vulvovaginal yeast infections, it's going to have a negative effect on the quality of life. It's going to negatively affect your work, your social life. And you're going to hear lots of advertisements for over-the-counter products with probiotics, prebiotics, other kinds of medicines that supposedly are going to help, and they really tend not to. In the overwhelming majority of women who have recurrent vulvovaginal yeast infections, it's not because you have a predisposing factor that we can identify, like taking an antibiotic or having diabetes or an IUD. Most of the time, it's due to a particular genetic susceptibility. There's some sort of an abnormality that you inherit that prevents your body from recognizing and fighting the yeast infection appropriately and keeping the yeast infection under control. And unfortunately, if the yeast infection is allowed to simmer and grow out of control, well, sometimes it leads to complications. Sometimes is the operative word here. So it could lead to pelvic inflammatory disease, ectopic pregnancy, spontaneous abortions, and pelvic abscesses and menstrual abnormalities. And if a woman is pregnant, the baby coming through the birth canal infected with the yeast might actually contract the yeast and then be able to spread it to the mother's nipples, because we know that the yeast tends to thrive in milk. So within a few days after birth, the mother might complain of flaky or stinging nipples, or itchy or cracking nipples, or maybe achy breast, or pain shooting in the breast after feedings. Now, Candida albicans has a dual life form. It goes from a commensal state where it lives in perfect harmony, doesn't cause any problems, but it could also be an opportunistic pathogen. And when the situation is right, it can strike. It has a dual life form. It's present in the typical round spore form, the Y form, or it can change into the hyphal form, the mycelial form, the pencil-like form that we call the H form. The H form is aggressive. And the H form is able to grow into the epithelial cells. It adheres to them, and then it penetrates the superficial layer. And when it does that, it incites an immune reaction, and that's when symptoms begin. Well, if we look at the vaginal infections, sometimes the microbes can form a biofilm. It's a mass that makes its own protective lining. And when we get the bacteria and the yeast and sometimes some parasites, other organisms in this biofilm, well, our medicines can't penetrate so much. And that can lead to some of these recurrences. We don't know exactly how important the biofilms are in vaginal yeast infections, but they're certainly very important in many different kinds of infections. And it seems that the H form of the yeast secretes something known as the secreted aspartoproteinase. And this chemical, this substance, has a role in adhesion and penetration and invasion, and it prevents the body's immune system from acting on the yeast. And the importance of this secreted aspartoproteinase is that it might form the basis of a vaccine. And actually that vaccine is being worked on at the present time. So it might be that we're going to have an answer that's much more satisfactory than our current one. Well, unfortunately, because of the widespread availability of over-the-counter medicines, and unfortunately because women frequently misidentify the cause of their vaginal infection, they use the medicines, and excessive exposure has led to an increase in the resistance of the Candida albicans to the standard medicines, and also to Candida glabrata and some of these other non-albicans type of candidas being quite resistant to the standard kind of medicines that we use. So the goal of treatment is to eliminate the symptoms, of course, and to cause the yeast not to be growing. But just because we have culture negative doesn't mean we've cured in the long term the situation. And as a matter of fact, even if at the time of treatment, right after the time of treatment, we get culture negative, so there's no yeast growing, if we have the woman come back in a month, a quarter of the time, just within a month, the yeast will be there again, and in 2/3 of the women it's going to be exactly the same strain of the yeast that they had, that we killed, that disappeared, and now all of a sudden from seemingly nowhere comes back. So we could use some antifungal medicines, or our antifungal medicines could be intravaginal medicines or oral medicines. If we use the intravaginal medicines, they're the azoles. They all work about the same. There's 85-95% success rate if the condition is indeed a vulvovaginal candidiasis and it's not the recurrence. Well, clotrimazole or miconazole or terconazole or thioconazole or butoconazole, they all work relatively well. Short-term therapy, anywhere between 1 and 14 days depending on the preparation, but you have to be a little bit careful because they're frequently oil-based and they can weaken the latex condoms and the diaphragms. Nystatin, well, that doesn't seem to work as well. It's okay in the intestine, but it doesn't really do as well as the azoles that I just mentioned in the vagina. And if they don't work, if the standard azoles don't work, we have to consider, well, maybe we got the wrong diagnosis. Maybe a person has bacterial vaginosis. Maybe a person has trichomonas. Maybe a person doesn't have a vulvovaginitis due to Candida. And then, working just as well, not any better than, but working just as well as the intravaginal medicines, we could use fluconazole or diflucan. That's an oral medicine, 150 milligram one time, one dose for acute vulvovaginitis due to Candida. That's all it takes. If a person has recurrent vulvovaginal candidiasis, well, oftentimes it's 3 doses, one right now and then one 2 or 3 days later, one 2 or 3 days after that. Sometimes what we do in women who have many recurrences is we do that. We can do it for up to 10 days in a row maybe, and then once a week for as much as 6 months. Oral medicine seems to be more acceptable to women, but the intravaginal products are more accessible because they don't need a prescription. Generally, we don't treat the male partner unless the male partner has some kind of symptomatic infection, but you have to realize that even if we use long-term therapy in women who have recurrent vulvovaginal candidiasis, right while we're using our therapy, 10 to 20 or 25% are going to have recurrences, and within half a year after stopping a 6-month course of antifungal medicines, 50% are going to have recurrences. So at least at the present time, it seems like we have a long way to go, and that's why the possibility of a vaccine is so exciting. Now, the problem is that with Candida glabrata, our standard therapies don't seem to work nearly as well. And then we compound different substances and try different kind of therapies, but we're not nearly as competent at treating Candida glabrata and some of the other kind of candidas as we are Candida albicans. So to prevent the condition, you wipe from the front to the back, you avoid hot baths, you avoid hot tubs, you don't douche, you avoid scented feminine products, you avoid sprays and pads and tampons, change the tampons often. There's no evidence that tight underwear is going to cause a problem, no special diets. You should stay away from colon hydrotherapy. There's no evidence in favor of the prebiotics, the probiotics, or even the suggestion that consuming yogurt is going to help you. The vaccine, that's on the horizon. We don't know when we are going to see it and when it's going to be presented to the Food and Drug Administration. Hopefully, it's sometime down the road. But at least what we can say at the present time is most of the time we're successful in our treatment. There's no difference between the oral medicine and intravaginal preparations for most women. It's just a personal preference. Unfortunately, some women are going to be burdened by multiple recurrences and need some kind of periodic suppressive therapy, often with fluconazole that must not be taken during pregnancy. And the good news, perhaps the best news yet, is as you grow older, the tendency to have these recurrences seems to decrease. So anyway, that's vulvovaginal yeast infections. Thanks for watching. I'm Dr. Ken Landau.